So, good evening everybody. Children represents a very special and interesting subgroup with regards to the diagnosis of uveitis and its management. And since they are having lesser complaints and the symptoms are very few in number, they present to us very late. And by that time, the disease has already established inside the eye. Since we are having limited treatment options because steroids are very much prone to cause growth retardation as well as mental retardation, and this age group is very much prone to amblyopia, so the visual rehabilitation is very much guarded. That's why I have decided that we will discuss this topic. The prevalence of pediatric uveitis is 2.2 to 21.6% worldwide as per the literature available. Anterior uveitis is the most common type of uveitic entity, ranging from 1/3 of to 3/4 of the total uveitic patients. Juvenile idiopathic arthritis is the most common type of etiology behind anterior uveitis, and in intermediate uveitis, still the etiology is idiopathic in nature. There is a long list of etiologies behind posterior and pan uveitis. Now coming one by one. Juvenile idiopathic arthritis is responsible for the 47% of the total cases of pediatric uveitis, and GIA is of three types: posioarticular, polyarticular, and systemic. Systemic GIA, there is no ocular manifestations. In India, posioarticular arthritis is found to be the most common among GIA. And this disease more commonly affects girls, and the mean age of presentation is usually 2 years, but it can be seen as early as at the age of 6 months. 75% patients are ANA positive, but in India, it doesn't hold true. If a patient is presenting at an early age onset, if he's a male, if he's ANA positive, HLA-DR5 positivity is there, and on first slit lamp evaluation, posterior synechia is present, it is going to be a bad prognostic indicator. Most of the patients are asymptomatic, eye is perfectly white. So most of the time they present as a chronic patients. That's why the complications in the form of band-shaped keratopathy, cataract, glaucoma, and CME are there. Initially, they should be treated with topical steroids along with cycloplegics, but to achieve the complete remission, we should go ahead with the oral steroids, but we cannot give them for a longer duration, so it is better to go ahead with the immunosuppressive agent. Sarcoidosis is considered to be a disease of old persons, but sarcoid can affect kids, and there are two types of presentation: early onset and late onset. Early onset, kids are affected below the age of 4 years, and they are characterized by skin rashes, uveitis, and arthritis, and because of that, they are most of the time misdiagnosed as GIA patients. But in sarcoid arthritis, the joints are swollen, boggy, there is no pain, and movement of the joints are minimally affected. Parotid involvement is more frequently seen in kids than in the adults, and the most common presentation of sarcoid uveitis in kids is granulomatous anterior uveitis. One thing that we will have to consider while evaluating these patients, that leukocytoclastic vasculitis is more common in kids than in the adults. While evaluating the investigation reports, serum ACE titer and lysozyme titers, they should be monitored very cautiously because they can be falsely positive elevated. In kids, they are higher on the side. In the cases of diagnostic dilemma, it is better to go for the lung or lymph node biopsy. What is happening? They are managed by the means of topical steroids and cycloplegics, but sometimes in the cases of intermediate uveitis, sarcoid can present like that, we will have to take the help of periocular systemic steroids or immunosuppressive agents. Now one more important differential should be there, that is TINU. It occurs because of the insult from some microbial agent or because of some drug, and these kids usually presents with uveitis along with fever, malaise, flank pain, hematuria, proteinuria, or pyuria. Uveitis can occur before, simultaneously, or after nephritis, and again the females are more commonly affected than the males, and the mean age of presentation is usually 15 years. It can be unilateral, TINU can be bilateral, it can be granulomatous, it can be non-granulomatous, but it responds to the steroids and immunosuppressive agents, but you will have to put your patient on long-term follow-up because ocular destruction is more than the renal destruction in TINU. Now coming to the intermediate uveitis, 90% cases of the intermediate uveitis are idiopathic in nature, and intermediate uveitis constitutes 1/6 to 1/4 of the total uveitic entities in the pediatric subgroup. Spillover anterior uveitis is more commonly seen in kids rather than in adults, and most common complication of intermediate uveitis in kids are cataract and cystoid macular edema. Systemic association of intermediate uveitis are there, but multiple sclerosis is rarely seen in children. But you should consider that if it's a female patient who is having bilateral intermediate uveitis with DR15 positivity, then you can think it can be associated with this multiple sclerosis. Most common pattern of intermediate uveitis is a prolonged course without exacerbations, and we follow here also modified Kaplan approach, but with a little difference. After, if a patient is not responding to periocular steroids, it's better to switch over to oral NSAIDs like naproxen, then you should plan for the oral steroids. Now coming to the posterior and pan uveitis. Toxoplasmo retinochoroiditis is the most common infectious uveitis, and toxoplasmosis can be congenital and acquired. In the third trimester, the highest transmission is there, but the maximum damage to the eye is done when it is transmitted in the first trimester. We all know that sabintestride is seen classically in congenital toxoplasmosis, and headlight in the fog appearance is typically seen in active lesions, whereas cartwheel lesions are seen in the old lesions, and most of the time in pediatric subset, these are incidental findings. In infants, IgM is of some help, but in adult patient, it is nested PCR along with Goldman-Whitmer coefficient. It can be helpful, but the diagnosis of toxoplasma is mainly clinical in nature, and we treat them with triple therapy, one sulfur drug, one non-sulfur drug, and corticosteroids. In recalcitrant cases, you will have to take help of your friends, VR friends. Toxocara, again, you will have to suspect if it is, there's a history of contamination of food with dog and cat species, two types, visceral larva migrans and ocular cysticercosis. You will have to rule out retinoblastoma because the age group and the presentation like leukocoria is seen in both the patients. Again, the diagnosis is clinical. If it is peripheral, simply observe. It is a posterior pole, go for periocular and oral steroids, but never start anti-helminthic drug if a live motile helminthis is seen there. Tuberculosis, very common in India, but in children it is highly uncommon, a little less common. Now, this is the case when I was a resident under JB sir. It was an 8-year-old girl who presented with hypopia and uveitis. Battery of investigations done, not responding to topical steroids, then switch over to oral steroids, not responding, then I went to sir. Sir did IAC tab, sent to cytology lab, and it was found to be a case of retinoblastoma. So beware of masquerades. They can be there. So the take-home message is meticulous history along with clinical, systemic, and ocular evaluation is a must, and we will have to achieve complete remission. I am very much grateful to my teachers, JB sir, SKG madam, Amla ma'am, Sudarshan sir, who taught me the nitty-gritty of uveitis. Thank you so much.